Hello, everyone. This is the after section 3 of structural heart disease. I am Dr. Yun-Hyeong from Yangji Hospital, Korea. I am the co-moderator of this session. Dr. Teiji Akagi is also the moderator of this session. Dr. Teiji Akagi, please introduce yourself.
Thank you. So thank you for attending for the structural view of the session. I'd like to introduce for the first presenter. The first presenter is Dr. Joo-Seong Lee. The title is presentation is the effect of diuretics in the HS defect in childhood. So please start.
Thank you for giving me the opportunity to present at such a great meeting. My topic is the effect of diuretics in the ASD size reduction in childhood. Although both transcatheter and surgical closures yield excellent ASD treatment outcomes, several studies have reported the superiority of transcatheter closure to surgery. Recent studies reported both lower peripheral success rate and an increased risk of complications with the use of transcatheter closure aid when body weight is below 15 kg or in the presence of a large secondary ASD. While diuretics are sometimes used in ASD treatment, their effect on ASD size reduction remains unclear. So this study aims to evaluate the efficacy of diuretics in ASD size reduction by comparing patients who received and did not receive diuretics treatment and their outcomes. We retrospectively reviewed the medical record of pediatric patients diagnosed with a large secondary ASD. Patients with other concomitant CHDs and those aged more than 10 years were excluded. The largest measured ASD size on echo was selected, and the ASD size was remeasured by a cardiologist who was blinded to the patient information. The primary outcome was the effect of diuretics on ASD size reduction and treatment outcomes. The secondary outcome was the identification of the risk factors associated with the lack of ASD size reduction and those related to the need for surgery. The initial age at diagnosis was higher in the diuretic than in the non-diuretic group, but the difference was not statistically significant. The follow-up duration was not significantly different between the two groups. Patients with the diuretics were prescribed on average a starting dose of 0.77 mg per kg per day furosemide and 0.81 mg per kg per day spironolactone. And the ASD diameter at diagnosis was larger in the diuretic and the indexed diameter was larger in the non-diuretic group. At the last follow-up, the ASD diameter and the indexed diameter were significantly smaller in the diuretic group. During the follow-up, the non-diuretic group showed significantly increased ASD diameter change compared with the diuretic group. The indexed diameter significantly decreased in the diuretic group during follow-up. And ibcilin deficiency was found to be more frequent in the non-diuretic group. Both the ASD and indexed ASD diameter showed a significant difference over time in both groups. The patient who received diuretics showed a significant size decreasing tendency over time compared to the non-diuretic group. And we investigated the distribution pattern in the two groups based on the ASD diameter change status. In the diuretic group, the ASD diameter was decreased stationary and increased in 20, 45, and 35% of the patient. In the non-diuretic group, none of the patients showed diameter decrease, and it was stationary and increased in 18.2 and 81.8% of the patients, respectively. And then for the identification of the factors affecting the ASD size change, the optimal cutoff diameter change and indexed diameter change values were calculated. The multivariable analysis, the use of diuretics was the only significant factor independently associated with the diameter decrease, and ibcilin deficiency showed borderline significance for diameter increase. And in the multivariable analysis for indexed diameter change, the use of diuretics was the most powerful factor associated with the reduction in the indexed AS diameter. We investigated the characteristics of the three subgroups according to the ASD size change in the diuretic group. None of the clinical features showed significant difference between the three groups. Posterior limb deficiency was the only factor that showed significant difference between the groups. And significant difference were observed for the distribution of treatment method. In the non-diuretic group, surgery was the most commonly used treatment, followed by device closure. Conversely, in the diuretic group, 30 patients underwent device closure, which was the most commonly used treatment, followed by surgery. ASD was reduced to a range that rendered treatment unnecessary in 2 patients in the diuretic group. So in pediatric patients with a large secondary ASD, diuretic may increase the likelihood of ASD size reduction on at least size maintenance. The likelihood of developing specific side effect from long-term diuretic use does not appear to be alarmingly high. There seems to be a little possibility of ASD size reduction in case of limb deficiency other than the aortic limb. Conclusion, the patient receiving diuretics may have a lower possibility to undergo surgery, and ASD size reduction by diuretics may enable the use of a smaller ASD device considering body growth for transcatheter treatment later. Thank you for your attention.
This is very important for the study, especially for the large ASD.
Yes.
And it may, if the maximum diameter of the ASD may reduce, it's a good and safe indication for the transcatheter closure, right?
Yeah.
So how long do you use for the diuretics before the ASD closure?
Usually average 1 or 2 years we use diuretics before device closure.
Oh, before the ASD closure.
Before the ASD closure, yes.
So you use for that 1 or 2 years for the before the ASD closure?
Yes.
For that use medication.
Yes.
But once start for the diuretics medication, probably the response is very quick. How do you think about it?
Pardon me?
Yeah, because the patient had that congestion, and after the diuretics you start, that congestion may reduce rapidly, very early, not for 1 or 2 years. Maybe that kind of the reduction for the ASD size may appear much more earlier, like 1 week or something.
Actually, our patient who use the diuretics does not appear congestion definitely. Actually, I'm not sure exact mechanism of ASD size decreasing tendency, but probably I suppose the right heart volume unloading maybe decrease ASD size, but mechanism was not clear actually.
So one question is on the chat. Are there any data show the change of the pulmonary artery pressure or right ventricular size?
Actually, when in device closure case, we measure the pulmonary artery pressure, but in non-diuretic group, almost patient undergo surgery, and actually we check the catheterization data, but pressure was not show definite difference.
Okay, thank you very much. It's a very wonderful, very, very important for the clinical practice. Thank you.
Thank you.
So I'd like to introduce for the second presentation. That is a retrospective case control study on head-to-head comparison between left atrial appendage closure and NOAC in the Asian population. Efficacy of stroke prevention and bleeding risk. Presented by Dr. Michael Cheung, Queen Elizabeth Hospital, Hong Kong. please start.
Okay. All right. Good afternoon, everyone. I'm Dr. Michael Cheung from Queen's Hospital, Hong Kong, and I'm honored to be invited to share my abstract here with you, a head-to-head comparison between the LAAO closure versus NOAC in AF or AFib patients in terms of their stroke and bleeding risk. I have no conflict of interest to disclose. So a brief introduction, AF has a high global prevalence of around 3% and is mostly asymptomatic. Around 8% of silent AF patients may have stroke as their initial presentation. So it has been well studied that both NOAC and LAAO were non-inferior to warfarin, with growing evidence showing even superiority. However, until very recently, there had been no data on head-to-head comparison between LAAO and NOAC. In mid-2020, the Prague 17 study was published in JACC, directly comparing NOAC and LAAO. Its primary endpoint is a composite one, including stroke, finish, significant bleeding, cardiovascular death, etc. So the primary endpoint showed that there's significant p-value for non-inferiority, but bear in mind that with the composite endpoint, the result itself cannot give a picture on the comparative stroke or the bleeding risk between the two groups. There are many ongoing studies on this topic, but most of them will take a few years before completion. Therefore, I conducted a study addressing this on Asian patients who are more prone to bleeding. So the primary endpoint of my study being the relative risk of LAAO and NOAC on stroke prevention, and secondly, on the relative risk of bleeding. It is a single-center retrospective case control study, and the inclusion criteria include adult patients with non-valvular AF or AFib, indicated for anticoagulation, and all patients with LAAO performed or NOAC started between February 2013 to November 2017 were included. Exclusion criteria, of course, if patients are contraindicated for NOAC or LAAO, the usage of inappropriate dosing of NOAC, changing of the NOAC type, crossing over between the two groups, or the termination or prolonged withholding of the NOAC within the study period. So within that designated period, we have 100 LAAO case with around 2,500 NOAC case. So each enrolling at different time point. How can we analyze this data to achieve a fair comparison between the two groups? To obtain a fair comparison, we have to look at a few parameters. The two groups of patients must have a similar stroke risk, similar bleeding risk, and also a similar recruitment to analysis duration. Hence, I employed the matching system. Within this inclusion period, a total of 100 LAAO cases were performed. For every LAAO case, it's matched with 3 best matching NOAC cases out of the 2,500 patients. So how was the matching done? It was based on the 3 principles we just mentioned. Firstly, similar recruitment to analysis duration. We chose cases with NOAC started within 30 days of the index LAAO implantation date. Secondly, similar stroke risk. We matched NOAC cases with the closest CHADVAS score as the index LAAO case. And similarly, for bleeding risk, we matched those with the closest HAS-BLED score. So we choose our own matching method rather than commonly used propensity score matching, as we find that the propensity score matching provides a less valid comparison in our case. There are 2 reasons. Firstly, same CHADVAS score or HAS-BLED score should correspond to the same stroke or bleeding risk, irrespective of the score component, which were the primary outcome of our study. For example, if the patient is suffering from hypertension and another patient is suffering from congestive heart failure, they should both be scored 1 in CHADVAS score and is deemed to have the same stroke risk, but will be considered different in propensity score matching. Second reason being that perfect propensity matched subjects would be ideal in that case, of course, but that would require a large number of patients to complete. So this is a schematic representation of the matching system we use. Every LAAO case is matched with 3 NOAC cases based on the aforementioned criteria. So we end up with 100 LAAO case with 300 matched NOAC case. So what are the results? This is the baseline characteristics of the 2 groups. As you can see, there's no significant difference in the CHADVAS score, follow-up duration, and the age. However, despite the best effort to match, the HAS-BLED score still remain higher for the LAAO group. As from the guideline, LAAO is still reserved as an alternative to these very high bleeding risk patients. Now we look at the primary outcome. First, looking at the stroke risk. As patients are enrolling at different time point, we perform time to event analysis and plotted on this Kaplan-Meier curve, which show that there's no statistically significant difference between the 2 groups for overall stroke risk, and also for the ischemic stroke risk. However, surprisingly, the hemorrhagic stroke risk was also not significantly different, which I'll go into more detail in a minute. For the bleeding risk, the LAAO group has significantly lower gastrointestinal bleeding, and you can see the curve appear to diverge even more with time. However, as mentioned, the intracranial hemorrhage risk was the same between the two groups. There were two main reasons for this. Firstly, remember the baseline demographics of the two groups. The LAAO group actually has higher Hesplet score to start off with, and hence are more prone to bleeding. Secondly, the intracranial hemorrhage is a rare event in both groups. Longer period of follow-up is needed to detect any significant divergence of the two curves. Finally, we look into the overall bleeding risk. The LAAO group has a lower overall bleeding risk, and the curve also appeared to diverge with time. We also performed a multivariate analysis on this group of overall bleeding patients, which showed that LAAO significantly decreased the overall bleeding risk, with the odd ratio of 0.19 compared to the NOAC, which translates to an 81% of relative reduction in overall bleeding risk. You may wonder, overall bleeding is a broad, non-specific term. Could the bleeding be just very mild? So that's why we further analyzed the overall bleeding group and stratified the bleeding severity by the TIMI bleeding scale. It was found that the majority of the bleeding in the NOAC group belongs to the category of requiring medical attention rather than minimal, which is not just statistically significant, but the magnitude of difference is high between the two. There are a number of limitations on our study, namely small sample size, small sample size, short follow-up duration, imperfect Hesplet score matching, recall bias on bleeding events, and finally, this data is performed on Asian patients only and may not be generalizable. So in conclusion, we compared the NOAC. When compared to NOAC, the LAAO has similar efficacy in all types of stroke prevention, with significantly less gastrointestinal and overall bleeding, with a relative risk reduction of 81%. Majority of the severity of the bleeding, which is not just minimal, but require medical attention. And finally, there's no difference in stroke, the risk of intracranial hemorrhage demonstrated between the two groups in the study, with possible reasons as just mentioned. All in all, I hope my study helped to shed early light on the long-sought gap in evidence, especially on Asian population, and I'm eagerly awaiting for the result of upcoming large-scale studies to fill in the remaining gap. Thank you.
Thank you, Michael. This is a very important issue especially for the bleeding complication in the Asian populations. Is there any questions for the panel?
Yes, I think this is a very important study, although it's retrospective, but I think it gives us a lot of information, especially for Asians. We are prone to more bleeding, and we have a different thrombosis profile compared with Caucasians. So I really anticipate more study like this, and I hope that Michael can continue to follow up those patients, because as you have said, we need a longer time, a longer duration to pick up those long-term benefits in terms of bleeding and stroke events.
Thank you very much, Simon.
Any questions? Actually, how about the dose of the NOAC, all of the appropriate dose, or that some patient may have a little bit relatively low dose of the NOAC? How about in your practice?
In the exclusion criteria, because we do see, because many of the times these patients are not being followed up under cardiology, is just atrial fibrillation, many of which are managed by a general practitioner or other internal medical practitioner. In that case, many of the times they know I actually underdose or having overdose resulting in bleeding events. So in the exclusion criteria, we actually exclude those group of patients.
Thank you. So we have time limitation. So thank you very much. So I'd like to move to the third presentation. Third presentation is a rare case of arrhythmogenic right ventricular cardiomyopathy with right ventricular clot and its potential complications and influence of the timing of insertion of the implantable cardio defibrillators. This presentation will be done by the Cheung T. Sultana Mina Hospital, Malaysia.
Thank you, Dr. Akagi. My name is Dr. T from Sultan Aminah Hospital from Malaysia, from the state of Johor, just at the tip of the peninsula. So my case today is just a case sharing and a bit of discussion point at the end. It's about a rare case of arrhythmogenic right ventricular cardiomyopathy with right ventricular clot and its potential complications and influence on the timing of insertion of ICD, implantable cardioverter defibrillator. I have no potential conflict of interest to disclose. So just a short introduction about arrhythmogenic right ventricular cardiomyopathy, ARVC. Typically, ARVC presents in young adults and they present quite suddenly with sudden cardiac death or resuscitated ventricular arrhythmias. The main pathological characteristic is replacement of the myocardium with fibrofatty tissue. ARVC may present biventricularly in 50% of patients, and even in a minority of patients only within the left ventricle. 3 stages are recognized. Early stages, which is subclinical, and there is usually no imaging features. And middle stage, where phase of ventricular infiltration is there, but there's no ventricular dysfunction. But the prominent feature at this stage is arrhythmias. And finally, late stage with overt right ventricular failure and variable degree of LV failure as well, and frequent episodes of arrhythmias. So I'd like to illustrate this topic with a case. This case happened locally at my center. A 19-year-old, previously healthy male with no family history of cardiac disease or sudden cardiac death, who collapsed during a stressful football game. All right, and at that time, there was a first responder, and resuscitation was performed together with an AED showing ventricular tachycardia, and then we subsequently reverted to sinus rhythm after defibrillation. I don't have the rhythm strip at the event, but this is a strip recorded during patient's stay in the coronary care unit. We can see a short VT, which subsequently reverted by itself, and some premature ventricular contraction seen. This is his baseline ECG, sinus rhythm. But what is prominent is the T-wave inversion, typically seen in the anterior leads V1 to V3. There's no right bundle branch block. There's also no epsilon wave seen. We did an echo at the bedside because patient was intubated. Showed EF was 66% with dilated right ventricle, but no clots were seen. So when the patient stabilized, we proceeded with cardiac MRI. And these are the images specifically taken to illustrate the point. Picture A and picture B showed transaxial cine in diastole and systole. It shows right ventricular dyskinesia and akinesia. There's not much difference. The RV volume is also increased. The end diastolic volume, which was indexed, was about 128 mils per meter square. Picture C is actually a short assist at mid-cavity at the late gadolinium stage, showing enhancement at the RV free wall, illustrated by the star. Picture D is the RVOT at early gadolinium, showing some saline defect at the apex, which is similarly seen in the RVIO view and also the horizontal long axis late gadolinium view. Also note presence of LG enhancement in the RV free wall and the inferior wall. But what is significant is there's presence of filling defect seen in both phases. This is the clot that I was talking about. So we started patient with anticoagulant, warfarin and also Clexane for bridging. This is images taken after 4 weeks of anticoagulation prior to ICD insertion. Similar 3 views, RVOT, RVIO, and also horizontal long axis. Early phase, no more filling defect. Late gadolinium enhancement is still seen at the free wall and inferior wall, but no more filling defect. After that, we proceeded with insertion of ICD, and patient were discharged successfully. So the main point I was trying to illustrate in this case sharing is that whether routine anticoagulation is recommended or not in all ARVC, mainly because we do not necessarily pick this up as a major complication of ARVC without looking at it. Generally, from many literature search, routine anticoagulation is not actually recommended. However, one must keep in mind fatal thromboembolic events may occur if this is not addressed adequately. I postulate that the formation of the clot may be contributed by a few factors. Mainly is RV dysfunction, very similar in pathogenesis to LV dysfunction. Also, in later stages of ARVC, there might be presence of RV aneurysm. In fact, there might be multiple foci of RV aneurysm where clots can also form in them. Of course, frequent ventricular arrhythmias, frequent arrhythmias that aborted by itself can also cause clots to form. And in certain cases, in patients with already an ICD inserted, when there are frequent shocks, clots may also be formed. So I'm trying to point to the fact that if you have effective imaging and appropriate therapy with anticoagulation, we may improve outcome and prognosis in such cases. So take-home message is to avoid dislodgement and propagation of clot during manipulation of right ventricle, especially during ICD insertion. We recommend an effort to find the presence of clot in ARVC, usually via advanced imaging methods, usually via cardiac MRI, as sometimes transthoracic echo may not be sensitive enough to pick up clots, especially in the RV apex. All right. However, most countries have begun to use cardiac MRI as a diagnostic and evaluation tool for the extent of structural abnormalities in patients with ARVC and finding associated features such as clot. However, that being said, based on literature research, RV clots are generally not commonly seen, even in the presence of advanced right failure, as compared to left ventricular dysfunction. So the main take home is keep an open eye for a clot forming in a patient with ARVC so that we can take the necessary measures to prevent complications. Especially when insertion, we can dislodge the clot and cause a massive pulmonary embolism. Thank you.
Thank you, Dr. T. I have a short question. Does he have any say in the finding about the pulmonary embolism for the?
This patient has no pulmonary embolism that we detected from the MRI. So he didn't present with pulmonary embolism. I guess it's fair to also think as pulmonary embolism as a cause of his collapse while playing football. But at that time, they did record ventricular tachycardia. So it's actually a resuscitated PT at his presentation. Yep.
Okay. Any questions from the panelists?
I have one question. So in your case, the cause of the embolism is due to the RV is dilated, or it is due to the RV aneurysm?
There's no aneurysm that I can see. It's mainly RV dysfunction. There's a kinetic area, dyskinetic area at the RV, and also the RV is also dilated. The EDV is about 128 mils per meter square. So it also fits the diagnostic criteria for ARVC for a dilated RV. The RVEF calculated from the MRI is roughly about 40%. Very borderline, yeah.
Okay, thank you very much. So I'd like to send the microphone to the Yun-Hyeong Joe for the following two presentations.
Let's move to the first presentation. Yeah, the first presenter is Dr. Namphon Sinchai. She's from Thailand. The presentation title is The Instance of Silent Ischemia Stroke After Transcatheter Aortic Valve Replacement in Severe Aortic Stenosis in Thailand using 3.0 Tesla MRI. Dr. Sinchai, please proceed.
Thank you. Good afternoon, moderator, panelists, and oral presenter, and all our audience. I'm Namphon Sinchai, neuroradiologist from Julapon Royal Academy. Today, I want to present my topic of incident of silent ischemic stroke after TAVI in severe AS in Thailand using 3 Tesla MRI. I have no financial relationship with any commercial product or vendors. As we know that TAVI has cause of neurologic complications such as silent ischemic stroke. In Thailand, first case was performed in 2012 with dramatically increased number in recent few years, but no incident of silent ischemic stroke in Thailand reported. So we aim to evaluate the incident and predictors. We collect the 49 patients with CVIS underwent TAVI during August 2019 to November 2020. We perform baseline MRI before and after TAVI within 2 weeks, and then we follow up images 1 to 3 months to evaluate chronic infarction. MRI sequence that we use first fast facet to detect bilateral lesion, SWI to detect microbleeds, DWI B1000 and ADC mapping to detect early infarction. So we collect the number of the new infarction, the size, the ADC value, the location, the vascular distribution, according to brain vascular territory, and as well as the new microbleeds. We use the linear regression analysis, both univariate and multivariate regression to determine the predictors of acute ischemic stroke following TAVI. We exclude 15 patient due to permanent pacemaker, patient chained to surgery, patient that no follow-up post-TAVI within 2 weeks, and the last one is intraoperative cardiac arrest. So total case is 34 patients. It is the patient demographic data. The age is, our average is about 78 years. The male is 64%, and prior angina is about 35%. Previous MI is about 12%, and previous PCI about 47%. The most underlying disease of patient is hypertension, and AF is 15%. STS score is about 4.5 in average. In echocardiography, no clot, and CTA, we collect the aortic valve calcium score and coronary artery calcium score, and it shows the score here. About the procedure, or patient exercise at the femoral artery, and the valve type, the main is self-expandable valve, about 65%, and pre-dilatation we perform in like 76%, and post-dilatation only 29%. About the duration of operating time is about more than 2 hours in average. Complication, we found failed hemostasis, 4 patients, and 1 patient has occlusion, valve dislodged, and valve misposition. After immediate TAVI, we use TEE to evaluate. We found paravalvular leakage in 23%, and aortic regurgitation in 4 patients. About MRI imaging, most of the patient has acute silent ischemic stroke after TAVI. Total lesion about 308 lesions, ranging 1 to 58 lesions per patient. About 60% size is less than 3 millimeters, and predominant at the left cerebral hemisphere, frontal lobe, cortical subcortical lesion, representing embolic nature. ADC value is ranged from 0.1 to 1.33, representing acute infarct with fewer varying ages of infarct. The affected vessel is middle cerebral artery, followed by posterior cerebral artery and anterior cerebral artery. We have only 2 patients that have major complication about neurologic symptoms. 1 patient has acute left hemiparesis. MRI DWI show acute large right MCA infarction with further investigation about MR angiography of the brain, and it shows severe stenosis at M1 segment of the right MCA, and patient has diffuse atherosclerosis. Another patient that has this Atrial after 5 days after TAVI, we found that the patient has acute left pontine infarction and embolic nature of ischemic stroke, and after 3 months, the infarction has resolved and developed into chronic infarction. So we found that 23% of the lesion changed to the chronic infarction, and furthermore, we found new microbleed in 8 lesions and macrobleed in 4 lesions, and some of the lesions are not associated with acute infarction location, like the disc that I show you The patient has embolic infarction at the right temporal lobe, but microbeat at the left parasagittal region. When we analyze in linear regression about the prediction of the number of cerebral infarction, we found that only while dislodge was independently associated with the number of the post-TAVI acute stroke. So the point that I want to discuss about is the first preliminary report of silent ischemic stroke in Thailand, while dislodge was only independently associated with the number of post-TAVI acute infarction foci and occur only one patient in our study. But I have limitation about the study that small sample size and it's just an initial experience in our institute. So we need to collect further case to find more of the predictor. To summarize, silent ischemic stroke is a common complication following TAVI with embolic nature. Most location is cortical subcortical region and size is less than 3 millimeter. Major neurologic complication occur in patients with pre-existing intracranial atherosclerosis with vascular stenosis. So pre-operative brain MRA could help with the early detection of significant arterial stenosis as it is a systemic atherosclerosis. Thank you for your attention.
It was excellent presentation. We have 3 panels. So panelists, please freely discuss and comment on this presentation.
Yeah, my first question is there any effect by the pre-dilatation to the stroke? Because you have a number of cases of pre-dilatation before you implement TAVI.
Yeah, we have pre-dilatation about 76%, but we have just 30% of post-dilatation because we have planning before. So it's to the valve. So the less incident of post-dilatation in our study.
So is there any correlation with the pre-existing calcium on the degree of calcium from the CT on the pre-assessment?
Yes.
And also for the valve dislodge, definitely I think would be a reason for more embolization.
Yes.
I guess maybe manipulation, the time of the number of manipulations we capturing that could also contribute to the stroke. So can I ask about what is the message that give after this study? Are you going to any way to prevent those strokes, or you want to pick up them routinely by MRI, or what would you recommend based on your findings?
I recommend to have baseline MRI before performing TAVI, and as well as systemic vascular imaging from head to femoral artery is crucial for like pre-operative evaluation or planning for treatment. Maybe we have some treatment, other treatment or procedure or intervention before TAVI for protection of further complication of the stroke.
I think some classical study will compare those patients who had used embolic protection then give rise to less MRI silent infarcts.
Yeah, especially that it seems that like a large majority of the patients has MRI evidence of at least a silent stroke. So maybe a routine cerebral embolic protection device is an option for patients undergoing TAVI.
Let's wrap up the presentation. So we have to go to the 5th presentation, but we don't have the 5th presenter. So now we freely discuss and comment on all the presentation, please.
May I ask Dr. Chi, the presenter for the 3rd case about the arrhythmogenic RV dysplasia? So if I didn't record, because I did not get all the case, my internet has been interruption. Did you anticoagulate the patients for a number of weeks before you put in a ICD? Is that the case?
Yes, we did. We in fact anticoagulated the patient for 4 weeks, and then we repeated the MRI, and the clot has disappeared. So therefore, we inserted the ICD after we made sure there's no more clot seen in the MRI.
Did you keep the patient in hospital during these few weeks of
Unfortunately,
anticoagulation?
yes. But 4 weeks he was kept in hospital for anticoagulation. We are worried that he might develop another cardiac event, an arrhythmia when he goes back. Yeah.
I see. So I think what is I were the physician. Of course, your options is definitely valid. Keeping the patient in hospital, making sure even he develops a arrhythmia that a prompt medical attention can be offered. Another option I was just thinking is probably if really early intervention should be considered, then a subcutaneous ICD may be an option.
Yes, but it is unfortunately not available in my center. So yeah.
Especially if there is no like pacing indication for the patient.
Yeah, it doesn't need any pacing.
Yeah, and did you give any antiarrhythmics during that few weeks?
We only put him on beta blockers, a low dose of bisoprolol, 1.25 mg daily, and throughout the 4 weeks, he has not developed another arrhythmia, provided that we kept him resting in bed, no exertion, and all that lah. That would help as well. Because if we allow him to go home, no guarantee that he might exert himself or not, because that will bring about further arrhythmias in this case. Yeah. So rest in bed in hospital and also beta blockers is our treatment at that time. Yeah.
And I think MRI is definitely a very valuable investigation modality, as you mentioned in your presentation. I think at least in Hong Kong, most of the time we will use MRI to characterize the myocardium. Yep. So which that is I agree with you. That is a arrhythmia is a condition that we should not miss.
Yeah, that's my point.
May I have one question to Dr. Sin Chai? When you follow up the patient, some patient already convert from the infection into the bleeding. So is there any specific characters for this group convert to macro bleeding?
Sorry, again, please. You mean when follow up? When I follow up, I follow up patient to 1 to 3 months and 1 year now, right now, and we found that the microbleed is persistent. And some of the lesion chronologically change to chronic infarction, but most of it disappear. Maybe it's from technique, MRI technique, or it's just embolic that maybe it's just like temporary infarction. We're not sure about this. But with follow up, the microbleed is persistent.
So may I ask about, would that affect your anticoagulation or antithrombotic regime after the TAVI? Because that is a very controversial topic. And some people give aspirin only or DAPT, and some people think about giving NOAC can cause less thrombosis over the leaflets. And I would like to know what you think about would MRI be a guide if you see microbleeds and you stop the anticoagulation or even aspirin or early termination or anything? So can you tell us what they're doing in your center?
Yes, now our center use we use heparin intraoperative, and now we go on the coagulation drug. Yes, and now MRI finding is not correlate with the clinical, is not affect the clinically changed or something. So in the clinician perspective, they continue treatment like severe aortic stenosis for like other people. It's no change from the their treatment.
So for the silent MRI changes, usually the classical correlation would be those cognitive impairment that is not be able to reflect from the patient's clinical presentation, but you have to catch them by doing the cognitive tests and also the NIHSS scores. So do you do all those scores?
Yes, we also collect the NIH score and cognitive test and neuropsychiatric tests like MMSE or MOCAR, and it's in processing to collect data analysis. So I didn't mention in this study.
There will be very interesting data.
And furthermore, not only taste, but we also collect the functional MRI of the brain to correlation about the taste, but in process.
I have a question to the first presenter, Ju-Sung Lee, Dr. Ju-Sung Lee. My question is, I'm curious about the diuretics effect. Do you think diuretics really decrease the size of ASD defect? So we can choose for less device. Do you think? Really think? Oh, he's not here. I think.
Actually, I agree with this presentation because especially for the adult patients, in some patients with very big ASD, in that situation, I will use for the diuretics few days, but not 1 year, 2 year, that few days. So the like a patient with atrial fibrillation and a large ASD, and 2 days, 3 days, just as a patient comes to the hospital admission, we start for the diuretics. So that kind of the usual regular dose of the diuretics reduced for the ASD size 1 or 2 millimeters.
Okay.
Only 1 or 2, but that is very important for the, especially for the large ASD, that we can close our device or send to the surgery. That I agree for this presentation, but mostly we use for the adult patients and not pediatric population.
Okay. So may I ask, if you decrease the size by diuretics and you put in this device that is, I mean, if it's very big, so you have downsize it and you can put in the biggest device. But what if the fluid status change? Would there be instability or would there be leaks around the device?
No, it's say final result is same, but like I say, for example, if we reduce for the 2 millimeter of the maximum diameter, it's a much more increasing for the successful rate, and procedure was much more safe and easier. And actually, that the diuretics to use for the simply chest X-ray shows that reducing the heart size using, especially usually adult ASD patients have not severe symptoms, so they didn't use any heart failure treatment. So once we can start with heart failure treatment, that probably effect for the heart size, the chamber size. I think it's a good idea for the large ASD.
So would that affect the shunt ratio across the ASD when you calculate?
I don't know. We don't evaluate about that, say, in that. But chamber size is definitely reduced. Yes.
Okay.
I have a question to Dr. Michael Chiang. Judging by your data, so which Asian patient will take NOAC or others will undergo LAAO occlusion? So what is your opinion about that?
Well, thank you for your question. So I think still up till this point, I'd say that no matter be the PROC 17 study or my study, the conclusion is still that we try to show that LAAO is non-inferior, but it's not actually superior to to NOAC, especially given that the NOAC data is getting stronger and stronger. It's very safe right now in most of the patients. So I'd say still NOAC in patients in Clot can tolerate will still be my first choice for the patients. It's only even with in Asian patients where they're more prone to bleeding, still the NOAC data is stronger compared to the LAAO if they can tolerate.
Okay. Is there any questions? Okay. I think this time is up, so we have to close this session. Dr. Akagi, please wrap up the session and do the closing remark, please.
Yeah, thank you very much. Probably we have meet someday near future in the on-site, and TCTAP for the thank you for the organizing TCTAP for the under this difficult condition. We hope to see you in Seoul in the next year, 2022. Yeah, to see in Seoul.
Yeah, we hope so. Yeah.
Yeah. Thank you. Thank you very much. Thank you all the presentators.
Yes, good luck for presentation.
Thank you.
Yeah, thank you very much. Yeah.
Thank you. So we close the session. Yeah.
Yes.